All right, welcome everyone. Today we are getting into a deep dive on what is arguably one of the most challenging realities in all of healthcare.
Yeah, medical error. It's a heavy one, but, absolutely critical.
It really is. And just to set the stage, our structural spine for this discussion is Chapter 7.11 on medical error from Kaplan and Sadok's comprehensive textbook of psychiatry.
Brilliant textbook. And our mission today, well, we really want to move past that sort of knee-jerk instinct to just point fingers and assign individual blame. We want to build a real mental model of how human fallibility and these massively complex system vulnerabilities actually interact.
Spot on. Because, if we think about it, psychiatry is fundamentally the study of how the brain, the mind, and our experiences interact.
Right.
And crucially, how that process can go wrong. So today, we're taking that exact same lens and turning it onto the practice of medicine itself.
Exactly. We're diagnosing the healthcare system.
Yeah. So I want to start with a metaphor to kind of anchor us.
Yeah.
Imagine, if you will, a highly complex, high-speed railway system.
Okay, I'm picturing it.
Right. So you've got hundreds of trains crisscrossing at terminal velocity. You've got these intricate electronic signaling networks that have to communicate in milliseconds. And, unpredictable weather, timetables compressed to the absolute limit.
Sounds incredibly stressful just structurally.
It is. Now, when a train inevitably derails in this horrible tangle of metal, the immediate human instinct, the front page headline instinct, is to ask a really simple question. Did the driver fall asleep at the wheel?
Right. We inherently want a face to blame. It's comforting, in a weird way. It resolves the anxiety.
Exactly. But a true, rigorous investigation treats that driver as just the last link in a very long, very broken chain. They have to ask, were the digital signals malfunctioning? Were the steel tracks warped? Was the scheduling so tight that sticking to the speed limit actually guaranteed a systemic collapse?
And that right there is the exact architecture of medical error. When something goes wrong in clinical practice, when a patient is actually harmed, it is almost never just an isolated clinician making a random mistake in a vacuum. The clinician is just the person, holding the metaphorical steering wheel when that catastrophic alignment of failures finally manifests.
The signals, the tracks, the schedule.
Exactly. So we're going to look at the mechanical anatomy of these errors, and especially how they show up in psychiatric settings. But to do that, we need to look at the history, because the stakes here are just staggering.
Oh, the numbers are terrifying. If we rewind to 1991, there was the Harvard Medical Practice Study, and they tried to quantify this collateral damage. They estimated that up to 1.3 million injuries occurred nationwide every year just to patients receiving standard hospital care.
Which is a massive number. But then came the real earthquake in 1999. The Institute of Medicine, the IOM, released a landmark report called To Err is Human.
I remember reading about that. It completely shook the medical world.
It did. They warned that between 44,000 and 98,000 Americans were dying every single year as a direct result of medical errors.
Just to visualize that, that's the equivalent of a jumbo jet crashing every single day.
Spot on. And you'd think, right, that bringing that into the light would fix it. But as data collection got better, the picture actually got worse. By 2013, John T. James published an update in the Journal of Patient Safety, arguing the true number of premature hospital deaths from preventable harm was over 400,000 a year.
Over 400,000. Wait, really? That would make it, the third leading cause of death in the U.S.?
Yes, right behind heart disease and cancer. And the British Medical Journal explicitly noted that very fact in 2016.
Wow. And globally, the World Health Organization, the WHO, in 2019, they calculated there's a 1 in 300 chance of a patient being harmed while just receiving medical care.
And we really have to look at the sociology of this data, too, because these errors, they don't just strike randomly.
Right, systemic bias.
Exactly. The system acts as an amplifier for broader societal biases. The data clearly shows that women and African Americans bear a completely disproportionate burden of these failures. The friction points in the system always catch the most vulnerable first.
It really forces you to realize that the system isn't some neutral machine. It's built by humans, so it inherits all our blind spots.
Absolutely. So for you listening, whether you're a psychiatry trainee trying to survive the wards or just a patient navigating a hospital, understanding how a mistake is made is literally a survival skill.
Okay, so let's unpack this. We need to define our terms first.
Yeah.
Because hospital corridors are full of mashed together jargon that just clouds the issue. So what is the actual difference between a medical error and an adverse event?
Good question. Let's draw a hard line there. An adverse event is harm that comes from a specific disease process, or it's a known, predictable risk of a treatment.
Like a side effect, essentially.
Sort of, but usually more severe. For example, if a patient develops profound neutropenia, a severe drop in white blood cells, while getting aggressive chemotherapy for leukemia, that is an adverse event.
Right, because it's a known statistical risk of a correctly prescribed, correctly executed treatment.
Exactly, no one made a mistake. But a medical error, that introduces the element of failure. The plan was flawed from the start, or the execution fell apart.
So an error usually leads to an adverse event, but you can have an adverse event without any error at all.
Spot on. And, crucially, you can have a massive medical error that, just through sheer blind luck, doesn't harm the patient at all.
Ah, the near miss.
Yes. And from a systemic learning perspective, near misses are gold dust. You get all the data on the failure without the body count.
That makes total sense.
Yeah.
Now, the IOM breaks errors down into two categories, right? Execution versus planning.
Yeah. An error of execution is a physical or logistical slip. The surgeon wants to operate on the left knee, but marks the right knee. Or a nurse means to program an IV pump for 10 milliliters an hour, hits an extra 0, and programs 100.
So the plan was perfect, but the physical reality just failed.
Right. But an error of planning is much more insidious. The execution is flawless, but the strategy itself is wrong. Like prescribing a heavy antibiotic for a purely viral infection.
The drug was given perfectly, the dose was right, but the aim was entirely useless.
Exactly. Now, Johns Hopkins University came up with a definition of a medical mistake that I think is really useful because it anchors it in time.
Right, they define it as an act of commission or omission that skilled peers would judge as wrong at the time it occurred, regardless of harm.
That temporal anchor is everything. We can't judge a 1990 clinical decision using 2026 data. If a doctor prescribed a drug 10 years ago that was the absolute gold standard, but now we know it causes heart failure, that wasn't an error.
Right, it strips away hindsight bias. It focuses purely on what the doctor knew in that specific moment.
Exactly. And this forces us into the biggest paradigm shift in modern medicine, moving from individual blame to systemic analysis. We have to look at individual versus systemic errors.
Okay, so an individual error is highly localized, the specific surgeon making the specific cut. But a systemic error is environmental.
Yeah. Imagine a hospital where the lab protocols for labeling blood types use this tiny, faded font on the barcodes, and the blood bank is chronically understaffed. That inevitably leads to a mismatched blood transfusion.
Right, so the nurse who hung the blood made the final individual error, but the environment practically guaranteed it was going to happen eventually.
Exactly. Modern patient safety says we have to stop hunting for the bad apple. If you just fire the nurse who made the mistake, but you leave those chaotic lab protocols and the terrible barcodes in place, the rotting barrel remains.
The next nurse will fall into the exact same trap. But here's my pushback on that. If we constantly blame the system, doesn't that create this massive diffusion of responsibility? I mean, if a doctor is just chronically careless, skips assessments, and relies on the system to catch their sloppy work, where does accountability live in a no-blame culture?
That is the critical tension, but we have to separate the terms. Blame and accountability are not synonyms. They are often operational opposites. Blame is punitive. It's retrospective. It's all about self-preservation. When a culture runs on blame, individuals hide their mistakes to avoid lawsuits or public shaming or losing their license. And a hidden error is a toxic asset because you can't study it.
So what does real accountability look like then?
Accountability is proactive. In a real safety culture, accountability is your ethical obligation to immediately report your own error, to participate in the terrifying root cause analysis, to dedicate your time to redesigning the system so your colleague won't do the same thing tomorrow.
So it's owning your role in the failure without being destroyed by it. You can't fix a machine if the mechanics are hiding the broken parts.
Beautifully put.
Let's look at those broken parts. The literature lists 5 primary mechanisms of error in general medicine: commission, omission, communication, contextual, and diagnostic.
Commission and omission are pretty straightforward. Commission is doing the wrong thing, giving penicillin to a patient with a red penicillin allergy bracelet.
And omission is failing to act, like discharging a bedbound patient after orthopedic surgery without a prophylactic blood thinner. You're practically guaranteeing a pulmonary embolism.
Right. Then we have communication errors, which are just the silent killers of the hospital. Information failing to pass between doctors or from doctor to patient. But the fourth one, contextual errors, is fascinating from a psychiatric viewpoint.
Yeah, this is where the medical team makes a scientifically perfect decision that is practically useless because they ignored the patient's lived reality.
Exactly. If you prescribe a highly effective psychiatric medication that has to be strictly refrigerated, but the patient is currently living in their car, that is a contextual error.
The pharmacology is sound, but the clinical reasoning is a disaster because you treated the disease and ignored the host.
Spot on. And that brings us to the heavyweight champion of mistakes: diagnostic errors.
Yeah, the Johns Hopkins research spanning 25 years of malpractice claims and a 2020 AHRQ report, they both confirm that diagnostic errors are the most common and the most fatal.
We obsess over the surgeon leaving a sponge in the patient or the wrong IV bag because they are tangible, physical. But the invisible cognitive process of forming a diagnosis is where the real harm starts.
And that process is vulnerable because human cognition relies on heuristics, right? Mental shortcuts.
Yeah, evolutionary shortcuts that save processing power but introduce massive bias. Take anchoring bias. A doctor fixates on the first piece of information they get and ignores all the subsequent data that contradicts it.
Or premature closure. The clinician just stops considering alternative diagnoses the second they find one that roughly fits.
Exactly. If a patient comes into A&E with chest pain and they happen to have a documented history of severe anxiety, the doctor might prematurely close the diagnosis as a panic attack, completely missing the evolving heart attack.
That's terrifying. Let's look at the physical vectors of these cognitive failures, though, starting with medications. The U.S. FDA reports over 770,000 patients are injured annually by medication errors.
Which is staggering. The Mayo Clinic developed a triad framework to understand this: medication factors, patient factors, and professional factors.
Right. So medication factors are the linguistic traps. Drugs that sound identical in a noisy A&E or look identical in a poorly lit pharmacy bin.
And patient factors introduce physiological complexity. We have an aging demographic. An 80-year-old doesn't metabolize a drug like a 30-year-old. Slower renal clearance, less efficient liver enzymes.
So a standard adult dose of a sedative might just build up in their bloodstream over 3 days until they suffer a toxic delirium and fall and break a hip.
Exactly. Plus, polypharmacy patients on 12 different meds from 4 different specialists who never speak to each other. It's a pharmacological minefield.
The final pillar is professional factors. Historically, that meant terrible physician handwriting or weird abbreviations. But today, the biggest professional factor is biological: fatigue.
Yeah. The old training system assumed doctors just didn't need sleep. In 2011, the ACGME, the Accreditation Council for Graduate Medical Education, finally stepped in. They capped first-year resident shifts at 16 hours.
Which sounds completely logical. Sleep-deprived brains make fatal errors.
Yeah.
But, and here's where it gets really interesting, this systemic intervention triggered a massive unintended consequence.
Right. The ACGME regulations engineered work compression. Interns had to do the exact same amount of clinical work, but in significantly less time. It spiked their baseline stress.
Wait, and if they work shorter shifts, that means they have to hand the patient off to another doctor way more often, right?
Exactly. The handoff passing care from the day team to the night team is the most dangerous moment in a hospital admission.
Because critical info just drops into the void between shifts.
Yes. The Joint Commission found communication and handoff failures were the root cause in nearly 2/3 of all Sentinel events. A Sentinel event being a preventable death or severe permanent injury. By mandating shorter shifts, you multiply the handoffs, which multiplies the errors.
It's the ultimate systemic paradox. You fix fatigue, but you create a communication crisis. I read that one hospital was using 24 different highly individualized acronyms just for handoffs across different wards.
It's clinical chaos. The surgical ward uses one acronym, psychiatry uses another, and the night float intern is trying to translate at 2 a.m.
Which brings us to the technological savior electronic medical records, or EMRs. They fixed the illegible handwriting problem, sure. But James Burnett and others mapped out how EMRs paradoxically birthed totally new categories of cognitive error.
Yes. The most dangerous is the copy and paste phenomenon, cloning. Interns have impossible patient loads. To save time, they open yesterday's clinical note, copy the whole block of text, paste it into today's note, and maybe just update the vital signs.
Right. And the psychological danger is that the chart looks incredibly detailed, but the clinical narrative has totally stagnated.
Exactly. If the patient developed a subtle new symptom overnight, but the doctor just pasted yesterday's all-clear assessment, that critical new data is just erased from history.
Then there's checkbox fatigue. EMRs are bloated with drop-down menus for billing. Clinicians just enter cognitive automaticity. They blindly click normal down a list of 50 physiological systems without actually doing the physical exams, just to clear the screen.
But the most devastating mechanism of error introduced by EMRs is behavioral, the destruction of the therapeutic alliance.
Because they're just staring at a screen.
Right. Studies show modern interns spend about 12% of their shift interacting face-to-face with patients and over 40% tethered to a computer. The EMR has hijacked the clinical encounter.
Think about the physical choreography of it. The doctor is in the room, but their back is turned. They're typing while asking questions. In psychiatry, the loss of eye contact is, well, you're losing your primary diagnostic instrument.
Absolutely. If a patient has a major depressive episode, they might say, I'm fine, but their body is screaming critical data. If you're looking at a monitor, you miss the psychomotor retardation. You miss the flattened effect, the downward gaze.
The software literally blinds them to the human being in the room, which is a perfect pivot to how these errors manifest specifically in the psychiatric specialty. Psychiatry is often left out of the general medical error literature, isn't it?
It is. It's often treated as an outlier. But S.W. Cullen and colleagues did a deep dive into inpatient psychiatric wards and found 4 distinct categories of error: treatment errors, diagnostic errors, preventive errors, and transfer errors.
Let's talk about diagnostic errors in psychiatry. There is this insidious phenomenon called diagnostic overshadowing. The stigma of a mental health diagnosis literally blinds the medical staff to a physical reality.
It happens all the time. Imagine a patient with a long documented history of severe schizophrenia. They show up at A&E with acute confusion, agitation, slurred speech. The triage nurse sees schizophrenia on the chart and anchors on it immediately.
So the doctor just assumes it's an acute psychotic break and orders heavy antipsychotics.
Exactly. But what they failed to investigate, because the psychiatric label overshadowed their curiosity, is that the confusion is actually from an undiagnosed glioblastoma, a brain tumor, or a severe systemic infection causing delirium.
Yeah, it is chilling.
Yeah.
And it works in reverse, too. A patient comes in with chronic physical pain, fatigue, stomach issues. The medical team runs endless, expensive scans looking for a rare autoimmune disease, completely missing that the patient is suffering from a profound, somatizing major depressive episode.
Right. Failing to look past the historical labels leads to catastrophic delays. But interestingly, the Cullen study revealed that the most common type of error in inpatient psychiatry wasn't diagnostic or medication.
Hey, really? What was it?
It was preventive errors.
Prevented, like failing to give a vaccine.
Not in psychiatry. In a psych ward, a preventative error is a failure of the environmental safety apparatus. The ward is built to prevent harm, so when harm occurs, it's a protocol breach.
Right, like failing to initiate fall precautions for an elderly, sedated patient. Or the big one, the breakdown of observation protocols.
Yes. A nurse gets distracted by a chaotic incident on the ward and fails to do the strict 15-minute visual checks on a patient with active suicidal ideation.
The fourth category Cullen found was transfer errors, which again highlights that systemic bias against psychiatric patients. This is when a general medical floor hastily discharges a really disruptive or uncooperative psychiatric patient before their physical workup is done.
Non-psychiatric staff just feel threatened or ill-equipped to manage the behavior, so they rush them out the door. It's an error born of stigma and discomfort.
Let's talk about the physical environment of the psychiatric ward, though. The locked unit. It's designed as a fortress of safety. Heavy doors, shatterproof glass, no sharps, no ligatures. Even life-saving medical equipment with tubes is banned from patient areas.
And that creates a lethal logistical trap, the ultimate paradox of safety engineering.
Explain that.
Picture a locked psych ward at 3 a.m. A patient suddenly collapses in cardiac arrest. The nurses rush in, but they need the crash cart, the defibrillator, the IV lines. Because of the anti-ligature rules, that cart is locked away in a separate medical closet, or even on a different floor.
So when the medical emergency team arrives, they're blocked by heavy security doors, waiting for someone with the right electronic badge.
Yes. The very infrastructure designed to protect the patient from suicide actively prevents the rapid intervention needed to save them from a heart attack. The safety protocol is the vulnerability.
Wow. Trapped behind your own defenses. And pharmacology in that environment is a minefield, too. The naming conventions for psychiatric drugs are a disaster. Look-alike, sound-alike drugs.
Oh, it's genuinely dangerous. Take citalopram, the SSRI antidepressant. Brand name Celexa. Now compare it to celecoxib, an anti-inflammatory for arthritis. Brand name Celebrex.
Celebrex. In a rushed verbal order at 2 a.m., they are indistinguishable.
Even worse, Zyprexa, the brand name for olanzapine, an incredibly potent atypical antipsychotic for acute psychosis. It gets confused constantly with Zyrtec, a basic over-the-counter antihistamine for allergies.
So if a violently psychotic patient is mistakenly given Zyrtec, the clinical team is going to be totally baffled when the patient's agitation just spirals out of control.
Exactly. And beyond the names, psych wards rely heavily on a prescribing method that acts as a massive error multiplier, the PRN order.
Pro re nata,
Yep.
Latin for as the situation arises or as needed.
Right. And the data shows that just dispensing a PRN medication increases the risk of a medical error by 15% compared to a scheduled daily medication.
Why does the risk spike 15%? Just because the timing is flexible?
Because it introduces profound ambiguity. A doctor might write, haloperidol 5 mg IM PRN for severe agitation, looks standard on paper, but in reality it shifts all the cognitive burden onto the nursing staff in the middle of the night.
Right. What defines severe agitation versus just moderate frustration? Are they pacing or throwing chairs?
And how many times can it be given in 24 hours? If they had a sedating med an hour ago, will this PRN dose cause respiratory depression? The nurse has to interpret a vague order, assess a volatile patient, and calculate pharmacological interactions on the fly.
So to fix that, systemic guidelines demand PRN orders be exhaustively specific. Exact clinical triggers, frequency limits, maximum 24-hour doses, and explicit contraindications.
Exactly. Now, we have to look at the darkest outcome in this specialty, inpatient suicide.
It's a staggering reality. 5% of all suicides in the United States occur while the patient is actively hospitalized inside a healthcare facility, usually by hanging or jumping. It is the ultimate failure of the psychiatric safety net.
It usually happens because the team underestimated the immediate risk, or the one-to-one constant watch protocol was breached by human distraction. But the textbook also delves into the psychological destruction of the clinician left behind.
The second victim syndrome.
Yes. When an oncologist loses a patient to aggressive cancer, there is deep grief, but it's expected. Psychiatrists are trained to believe that with enough vigilance, every single suicide is preventable. So when a patient dies on the ward, the clinician experiences an acute trauma response.
Profound shock, intense shame, obsessive guilt.
They forensically dissect their own notes. What microexpression did I miss? Did I stop the one-to-one observation a day too early? Was my therapeutic rapport just a delusion? It's a severe moral injury.
And many exceptionally talented psychiatrists just abandon clinical practice entirely or defensively refuse to treat high-risk patients. The ripple effect is devastating. It just underscores why structured, non-punitive peer support is critical hospital infrastructure.
You cannot treat doctors like disposable liabilities after a tragic outcome, or the profession just bleeds talent.
Right. Another incredibly high-stakes intervention is physical restraint and seclusion. When an agitated patient is physically strapped to a bed, the margin for error drops to absolute zero.
Mistakes there lead to severe physical injury, asphyxiation, or cardiac arrest from sheer exhaustion while fighting the restraints.
Because the human rights and physical stakes are so extreme, the Centers for Medicare and Medicaid Services, the CMS, built incredibly rigid frameworks around it. It's an absolute last resort.
Right. If a patient is restrained, the doctor can't just write an order and go to sleep. The CMS mandates a face-to-face evaluation by a physician within exactly 1 hour of the restraints going on.
Continuous one-to-one physical observation, constant vital signs. The administrative burden is intentionally immense just to force clinicians to find alternative de-escalation strategies.
Exactly. So we've mapped the minefield, the cognitive traps, the PRN ambiguities. How do psychiatrists actually engineer their way out of this? Let's move into integration and clinical reasoning.
Right. The American Psychiatric Association publishes these dense, evidence-based practice guidelines for major disorders, but they attach a massive legal caveat to them.
And that caveat is the shield protecting clinical autonomy. The APA emphatically states that practice guidelines are patient care strategies, not inflexible legal standards of care.
That is a vital distinction. A standard of care is what a reasonably prudent clinician would do. A guideline is just a statistical average of best practices.
And humans aren't statistical averages. A doctor has the legal and ethical authority to deviate completely from a published guideline if the unique patient sitting in front of them demands it.
The ironclad rule, though, is documentation. If you deviate, you must explicitly write out your clinical reasoning in the chart, explaining exactly why the standard guideline would harm this specific patient.
The real danger is when hospital administrators or insurance companies weaponize these guidelines for financial efficiency, offering doctors bonuses to stick rigidly to the cheapest algorithmic pathway. It incentivizes cognitive laziness.
Over-individualized clinical reasoning. Let's look at a concrete systemic solution. We talked about medication errors. The primary weapon against them is medication reconciliation.
The Joint Commission made this a national patient safety goal in 2005 because the data showed almost 28% of discharged patients couldn't accurately name the medications they were supposed to be taking at home.
28%. So medication reconciliation is this highly formalized process of creating an exhaustive list of every single chemical a patient is ingesting. Prescriptions, over-the-counter, herbal supplements.
Verifying the name, dose, frequency, route. And this list must travel with the patient across every transition, from the GP to A&E to the psych ward and back home. Skip it, and you guarantee a vital med gets dropped or a dangerous duplicate gets added.
We also talked about the extreme danger of shift handoffs.
Mm.
The solution to those 24 conflicting acronyms is a structured protocol called the IPASS handoff curriculum. How does that work?
It's a masterpiece of cognitive engineering. IPASS stands for illness severity, patient summary, action list, situation awareness and contingency planning, and synthesis by receiver. It forces chaotic data into a chronological structure.
But the genius step is that last one, synthesis by receiver.
Exactly. The incoming doctor can't just nod and say, got it. They must verbally repeat back their understanding of the most critical tasks and potential emergencies. It totally closes the communication loop.
And when they piloted this across pediatric residency programs, it yielded a 23% drop in overall medical errors and a 30% reduction in preventable adverse events.
And it didn't add a single minute to the handoff time. It just replaced chaotic rambling with high-density data transfer.
Proving that standardization protects clinical care. Let's look at another brilliant hack, the visual traps of sound-alike drugs like the Zyprexa and Zyrtec. The FDA endorses a visual intervention called tall man lettering.
This is a fascinating look at the neuroscience of reading. The human brain is a pattern recognition machine. Experienced clinicians don't sound out letters. Their visual cortex recognizes the overall shape of the word.
Right, cognitive automaticity. Because Zyprexa and Zyrtec have similar lengths and start with Zy, the brain sees identical shapes.
So tall man lettering intentionally breaks that automaticity by capitalizing the unique distinguishing letters in the middle of the drug name. Zyprexa is Zyprexa. Zyrtec is Zyrtec.
It injects a visual irregularity that acts as a cognitive speed bump. It forces the brain to drop out of passive pattern recognition and revert to active letter-by-letter processing,
Effectively neutralizing the selection error before the prescription is even signed.
elegance in simplicity. Now, let's tackle the hardest question in this deep dive, the aftermath. Say the Swiss cheese model aligns perfectly. The tall man lettering fails, the handoff drops the data, I make a clinical mistake, and my patient is harmed. My biological instinct is self-preservation. I want to bury it so I don't get sued. How do we dismantle that instinct?
It requires destroying the blame game architecture of the hospital entirely. Historically, mistakes were discussed at morbidity and mortality conferences, the MMCs.
Which were essentially tribunals in toxic hospitals. A junior doctor at a podium while senior attendings interrogated and humiliated them.
Right. It taught doctors exactly one lesson: never admit a mistake. Modern safety literature says we must transform these into case-based error reduction conferences, or CBERCs.
The psychological shift there is profound, isn't it?
Massively. A CBERC removes the individual from the crosshairs. The whole conference maps the systemic flaws that permitted the human error to reach the patient. Plus, it incorporates psychological first aid for the clinician, the second victim.
Because you can't improve safety if your staff are crippled by unaddressed trauma. But that's internal. What about the patient in the room? Doctors are terrified that disclosing an error is just inviting a malpractice lawsuit.
And here's where the data reveals a profound truth. Patients have an absolute ethical right to know, but pragmatically, transparency is the ultimate legal shield.
Really?
Yes. Extensive studies show that when a physician sits down, explains the error clearly, and offers a genuine, unguarded apology, a true, I made a mistake and I am deeply sorry, not a legally evasive non-apology, the rate of malpractice litigation just plummets.
Wow.
Up to 70% of malpractice lawsuits are initiated in the complete absence of a meaningful doctor-patient relationship. Patients rarely sue doctors they trust, even when devastating mistakes happen. They sue doctors who avoid them, lie to them, or act arrogantly.
The therapeutic alliance is the most powerful risk management tool in existence. That is the ultimate vindication of empathy. However, the text outlines a highly controversial exception: therapeutic privilege.
Ah, yes.
This suggests a physician can intentionally withhold information about an error if they believe disclosing it would cause the patient irreparable psychological harm. I mean, I find this terrifyingly subjective. It feels like the ultimate paternalistic loophole. Who gets to decide the truth is too dangerous?
The modern bioethics community shares your exact revulsion. It is intensely paternalistic. The theoretical argument usually relies on extreme edge cases. Imagine a profoundly fragile, actively suicidal, paranoid patient. The pharmacy makes a minor dosing error that causes zero physical harm, a near miss.
Okay, so the physician argues that disclosing this harmless near miss would shatter the patient's trust and trigger a catastrophic paranoid break.
Right. In that highly specific scenario, they argue the duty of non-maleficence, doing no harm, temporarily overrides the duty of transparency. But in modern practice, therapeutic privilege is viewed with extreme hostility. It's been historically abused to cover up incompetence. The consensus today is that transparency is non-negotiable.
And the transparency is being legislated into reality. Look at the regulatory frameworks. In 1996, IPA established standard protection for digital health data. In 2009, the AITA-Tech Act injected billions to force the adoption of electronic health records. But the radical shift came with the 21st Century Cures Act.
Yes, for decades, psychotherapy notes were the closely guarded property of the psychiatrist. The Cures Act obliterated that wall. Now, open notes is the law. Patients have immediate digital access to read their clinical psychiatric notes.
It's a phenomenal shift toward democratic healthcare. It demands clinical clarity and respect in the documentation. And from a safety perspective, the patient becomes the ultimate auditor of their own chart.
Spot on. If a doctor uses the copy and paste function and propagates an old incorrect diagnosis, the patient reading the open note can instantly flag the error.
Turning the patient into the final safety net. Brilliant. We've covered a colossal amount of conceptual territory today. Before we close the loop, we're going to stress test our own mental models. We have 7 scenarios based on the mechanisms of Chapter 7.11. I will set the stage, we'll give you a second to think, and then our expert will dissect the underlying logic.
Let's do it.
Question 1. Focus. The core concept. A patient undergoing necessary chemotherapy loses all their hair, while another patient receives the wrong chemotherapy drug due to a pharmacy mix-up, but miraculously suffers no ill effects. Conceptually, how do we categorize these two events? Pause.
Right. The hair loss is an adverse event. It is a known, predictable harm from a correctly executed treatment. No failure occurred. The pharmacy mix-up is a medical error, specifically a near miss. It involves a fundamental failure of execution, even though it didn't result in an adverse event. The presence of system failure is the dividing line.
Spot on. Question 2. Focus. Psychiatric mechanisms. Based on the Cullen study, if you were auditing a locked inpatient psychiatric facility, which category of error should you statistically expect to find most frequently, and what does it look like? Pause.
You will most frequently find preventive errors. In this environment, it means the failure of the ward's safety infrastructure. It looks like clinical staff failing to strictly adhere to 15-minute staggered observation protocols for a suicidal patient, or failing to maintain environmental fall precautions.
Excellent. Question 3. Focus. Clinical systems. An exhausted registrar at 2:80 a.m. is staring at an electronic prescribing menu, trying to rapidly select an antihistamine, but the menu is populated with powerful antipsychotics that share the same first 3 letters. What specific visual engineering system must the software employ to stop the cognitive automaticity of the registrar? Pause.
The software must employ tall-man lettering. By capitalizing the unique internal letters like ZYRTEC versus ZYPREXA, the visual disruption forces the brain out of passive pattern recognition and demands active cognitive processing, breaking the error chain.
Question 4. Focus. Systemic paradox. The ACGME strictly capped intern shifts at 16 hours to eliminate the catastrophic errors caused by extreme sleep deprivation. However, this intervention birthed a new vector for medical error. What is the precise mechanism of this unintended consequence?
The mechanism is the massive multiplication of patient handoffs, combined with work compression. Shorter shifts mean care is transferred much more frequently. Every handoff is an opportunity for data to be dropped. Without a universal structured algorithm, communication failures outpace the benefits of a well-rested brain.
Question 5. Focus. Bioethics. A psychiatrist realizes they accidentally prescribed a slightly incorrect but completely harmless dose of an anxiolytic to a patient with severe health anxiety. Fearing that admitting the mistake will cause a catastrophic panic attack, the doctor decides to hide the near miss. What specific doctrine is the doctor invoking, and how does modern ethics view it? Boss.
The doctor is invoking therapeutic privilege, arguing that doing no harm overrides the duty of transparency. However, modern bioethics views this with extreme hostility. It is highly subjective, fundamentally paternalistic, and full disclosure is the overwhelmingly preferred ethical standard today.
Question 6. Focus. EMR vulnerabilities. Electronic medical records successfully eradicated errors caused by illegible physician handwriting. However, they inadvertently caused a spike in diagnostic errors within the psychiatric assessment. What is the behavioral mechanism behind this failure? Pause. The mechanism is the destruction of the visual therapeutic alliance. EMRs demand intense data entry, forcing the clinician to stare at a monitor rather than the patient. This loss of eye contact means the clinician is completely blind to subtle, non-verbal diagnostic clues like psychomotor retardation or evasive body language, which are the foundational data points of a psychiatric diagnosis. Spot on. Final question. Question 7. Focus. Cultural shift. A hospital decides to ban traditional morbidity and mortality conferences and replaces them with case-based error reduction conferences, or PSYCH. What is the fundamental psychological and operational shift they are trying to achieve?
The shift is from individual blame to systemic accountability and emotional recovery. They are eliminating the culture of interrogating the bad apple. PSYCH objectively map the environmental flaws that allowed the error, while simultaneously providing structured psychological support for the clinician, the second victim.
Outstanding.
Yeah.
Now, we strongly urge you to read Chapter 7.1 in the comprehensive textbook of psychiatry alongside this discussion. Our models are only as good as the primary text they are built upon.
Absolutely read the text. It's essential.
Before we leave you, I want you to consider a rapidly approaching paradigm shift. We have spent this entire deep dive forensically examining how human biological limits, fatigue, cognitive bias, trauma, inevitably cause devastating medical errors.
Yeah, the human factor.
Right. But the landscape is shifting. Artificial intelligence has entered the diagnostic space. AI models can read 1 million charts a second, cross-reference every known pharmacological interaction, they never require sleep, and they never suffer from anchoring bias. So, will AI finally be the ultimate systemic tool that eradicates human medical error?
Or will it merely introduce entirely novel, hyper-accelerated systemic errors, algorithmic biases hidden in black boxes, digital hallucinations that our flawed human brains won't even recognize as errors until the damage is already done?
That tension between human fallibility and algorithmic inscrutability is exactly what will define the next era of patient safety. We must ensure we don't just trade one type of invisible error for another.
Here are the details of this episode.
Medical error. Byline. The greatest threat to patient safety is not human imperfection. It is failing to learn from it.